Okay, let's get started. Welcome, everybody. I'm Josh McHour. I'm a professor of medicine and bioengineering here at Stanford and the director and co-founder of Stanford Biodesign and our policy program. You're receiving this webinar today as one of our main outputs of our policy program. We really want to try to keep our community well informed of the issues that are pressing and relevant to current policy. And there's probably no greater area of interest than AI and digital when it comes to how are we going to navigate this new world, find payment for it, and really create the opportunity for greater access for patients and hopefully better outcomes. So I will now hand it over to Sandra Ruggles. Dr. Ruggles is the director of research policy here and policy research here. And welcome to the webinar today.
Thanks, everybody. I appreciate you being here today. So our plan for today's webinar is to spotlight a recent publication that was co-authored by members of our policy program. And I think it's important here to kind of put this into context for everybody, and then we'll do some introductions. So, every day we're seeing new announcements of how AI and digital tools in general are changing the landscape of healthcare. Recently, we've seen news as varied as a Peterson Institute's report with a new white paper around how AI scribes are being adopted into healthcare settings, as well as just within the last week or two, the launch of Amazon Health's first health AI chatbot in its beta stage. So I think we're seeing an explosion of use cases of how digital tools and AI can be integrated into healthcare. We are seeing a lot of active experimentation and uptake into the healthcare ecosystem writ large. But the value of many of these digital tools is still to be determined. That's why I'm so excited today to host this webinar that really spotlights this recent paper, the Digitally Enabled Care Framework, leveraging technology to enhance the physician-patient relationship. And so for today's webinar, we're going to follow this agenda. On the left-hand side, I'll do some introductions to the co-authors who are participating today. Kevin Schulman is going to give us an overview of the paper. Stacy Wood's going to talk about implementation and some of the marketing theory that underlies this. And then we'll have Rory Thompson talk about his own real-world experiences with it. I'll ask a couple of questions in our discussion, and then we'll move to a Q&A. So for those of you who are participating in the webinar, there is the ability to ask us questions. And so please put your questions into the Q&A rather than into the chat. And we'll be curating those questions to use towards the end of our hour together. Free range there. If you've got ideas and questions that you want to ask, please feel free to share. For those of you who want to pull up the article itself, I've put a QR code and the web address here on this slide so that you can pull it up and take a look at some of the figures and some of the detail associated with this paper. I think it's a really comprehensive effort, and it's one of the reasons that we really wanted to highlight this paper is just how much work and thought and detail has gone into thinking about this digitally enabled care framework. So with that, let me move to introductions of our co-authors who are on the webinar today. We have Kevin Schulman, who is a professor of medicine here at Stanford University and the co-interim chief of the hospital section. We have Stacy Wood, who is a distinguished professor of marketing from Duke University, and we have Rory Thompson, who is one of our policy program policy fellows. He has a background in primary care and has most recently been spending his fellowship year with ARPA-H. So I think we're going to have some really exciting insights from each of these folks, and I'll hand it over to Kevin at this point.
Great. Thanks, Sandy. And as I'm pulling my slides up, let me thank you and Josh for including us today. We should have a lot of fun. I just want to clarify, Stacy's a professor, adjunct professor at Duke, but chaired professor at NC State, which is why the logo is right behind her, just so she can remind us. Stacy and I have had the opportunity to work with Rory during his fellowship program here, but Stacy and I have worked together for many years now. And Stacy, I ran a master's program at Duke, which we now have here at Stanford, looking at clinical informatics and the relationship between business medicine and technology. And I was fortunate enough to be able to recruit Stacy to be the marketing professor in that class. And this was all people interested in digital applications in healthcare, kind of predated LLMs anyway. AI was probably still around. But she's really become fascinating over the last decade in all the different ways we could think about applications of marketing to healthcare services. And she'll tell you a lot more about that. But as in medical school, we learn how to take care of patients. Well, we learn how to take care of one patient at a time, and that's a very analog process. But when we think about a world of digital tools, we're going from analog, this analog clinical care to taking care of many people at a time. And that really is going from clinical realm to the marketing realm. And that's really the impetus for this paper and for this conversation. So, great. So let me talk about this idea as a framework for both high tech and high touch, or high touch and high tech. How do we bring together the best of both worlds? This collaboration with Stacy has really been amazing. She was former editor-in-chief of the Journal of Consumer Research, president of the Consumer Marketing Association. And so really is at the cutting edge of consumer and behavior research. And so bringing together the clinical team, technology perspective, and the marketing perspective all came together in this paper. Stacy also coined the digitally enabled care after much back and forth. Sandy already showed us the paper that we got in New England Journal Catalyst. But this is in our idea, and I'll talk about more with the graphics, of thinking about the services that you should get. So as you think about your life and all the different digital services you get in every different realm of your life, we just don't provide those in healthcare. And we don't have, as Andy said, where's the value? The Biodesign program is about needs-based innovation. What are the needs for patients? How can digital services meet those needs? And then I'll come back to an idea of how do we have to pay for them. So here's a mock-up on of a screen that we have in the paper that could help the patient get ready for their digital visit. And I'll talk more about each of these ideas of both education, helping the patient understand what their data are, but most importantly, how do I come to a visit, get what I need out of that visit, and move forward. So we came up with this digitally enabled care framework. Again, thinking about if healthcare was the same as every other service in your life, what are the ways in which digital tools could be used to provide services to patients? And we broke it up into 3 different segments: the pre-visit, the visit, and the post-visit. The pre-visit is around active preparation in health literacy and stress reduction. The visit's about engagement, agreement, and coordination. And post-visit's about reinforcement, engagement, and activation, and logistics. And so we'll come back to that in a second. But what you see here is an idea of ways in which we could use digital tools to enhance patients' value from a clinical visit, to enhance patients' engagement with the care process and care team. And as you'll see, a whole new suite of services that are really available to us that just don't exist right now. So in the pre-visit period, so I should say the digitally enabled care model, doesn't require, is about in-person or video or televisits. So this could be applied to any kind of care engagement. But pre-visit, before a patient comes in. So you get a nice little email from Stanford saying, you're going to have a clinic visit with me this coming week. Get ready to pay your copay. That's about all they tell you to do. So how do you get ready for a visit? So the first question is, what are my questions? Like, how do I'm about to spend, or my health plan's about to spend a couple $100 on me, maybe a couple $1,000 on me. How do I make sure we get the most value out of that engagement? What is it where is my health right now? What do I know about my health? Where am I at my cancer screening? Where am I in my vaccines, medications or side effects? How do I get a summary of all that information? And then the next thing is about health literacy. So how do I prepare? The doctor told me I have diabetes or high blood sugar or pre-diabetes. I really don't know what that means. But maybe I want to find out a little bit more before I talk to the physician about what I should do next. And then, we talk a lot about this idea of white coat hypertension, but how do it's stressful. I got to go park, I'm late. The clinic makes me wait. The person at the front desk, if I'm coming in person, isn't paying any attention to me as they're playing their video games. So it's incredibly stressful to a lot of people to actually go to the provider. So how do I reduce that stress? How do I build meditation in, or get them a chance to really understand who their physician is or trust their physician in advance? So this is all kind of pre-visit services that we can provide. And as we're walking through this, all this makes sense. And then we had some very specific ideas here that I don't have time to go through right now, but we can come back to possibly later. During the visit, the things that we have to do during the visit are build engagement and trust. How do I trust my provider? Again, whether in person or virtual, whether it's the first time I've ever seen this person or I'm seeing somebody I know very well. How do I build agreement about a treatment plan and actions that are required? And how do I help understand coordination of a lot of different resources about radiology, testing, labs, and specialty services? So the first piece is to make sure that we're sharing information. So imagine in the pre-visit period, we decided there were 3 questions I absolutely had to ask the doctor about. So again, go back to the pre-diabetes things. Do I have to change my diet? Do I have to take a medication? Are there lab tests that I should do? So as a patient, I come into the visit with questions that I really need to make sure I get answered during the visit. The agreement piece is based on this information, so the physician now knows the 3 questions I want to get out, because I had enough time to actually, as a patient, work up those questions, and then those are shared with the doc. And so we go through all that, plus whatever else might be coming up. I could share lots of new data. All of us are, probably running around with smartwatches that can track all kinds of health information, but we never share those with our providers. But also when, Apple tells you you have sleep apnea, do you need to be concerned about it or not? What are the other providers you're seeing? Where are you in terms of your clinical care journey? And how do I help you understand and make progress with all of those tools? So again, these are ways in which the interaction with the clinician can be enhanced by the pre-visit work that we just talked about. But also all of this information at the end of the visit should be available to the patient. Um, you know, um, one of the things that we're working on right now at Stanford Hospital is discharge planning, and we talk about, going through the medications with the patients on the last day of the hospital. So Mrs. Jones has been in the hospital for 3 days with pneumonia. She's been on oxygen. She's had a high fever. She's not really feeling very well. She's very stressed out about the car coming to pick her up, to bring her back home, to worry about what's in the fridge. How's she going to eat? She feels really weak. And then I send a nurse at $200 an hour to go talk to her about her medications, and she could care less at that point. That's not a great time to intervene. So how do I get that information back to her at a time when it might be accessible and she has time to really sit down and, relax and concentrate? So again, this information should be available to the patient after the visit. And for our discharge planning solution, why don't I just give her a QR code and tell her to click on this in 2 days? But the piece about the model that I really like is this idea of post-visit. This is an area that just does not exist right now. And again, the big themes that we built were reinforcement, engagement, and activation and logistics. But after a visit, I see you in clinic, I write a prescription and then say, good luck, see you next year. But how do I review the materials or how do I review the transcript of our conversation? What about materials? What about educational materials after the visit? Again, we're talking a lot about diabetes. So what information do I as a provider share with you about diabetes? And is it in your language at your reading level? And then all of you have been to healthcare where you get a piece of paper. Most of the times with that piece of paper might get printed from the electronic health record or from a third-party vendor. It's not coming from me. And it's in paper. You forget about it, you lose it. Why is it not in video? We've just, look at my kids, like they learn everything there is to know. One of my kids is going through med school right now. It's all on video. Like they don't sit down and stare at a book anymore. But yet in healthcare, we constantly give people pieces of paper, not at their reading level, not in their native language. So I want to be able to send patients home with information in their language at their reading level in video. And so a whole new opportunity for education around specific medications. Here's how to take your meds. Education about how to access the healthcare system, how to follow up, review your prescriptions, make sure you get them, have some way of linking back if you have trouble. And then a journey map of either tests, again, that are scheduled. This is why it's important to get your mammogram. This is why it's important to get your colonoscopy. And then, heaven forbid, it actually pre-populates your calendar so you don't forget. From a financial perspective, we were talking about value. Why do you want to do this? Well, this model with these digital services around patient engagement really could drive lower costs of care. So if people take their meds and control their blood pressure, control their diabetes and hypertension, because they're engaged, they're going to be much less expensive for the healthcare system. So, the other piece of magic here is customizing the information. We talked a lot about language and reading levels, but think about a world of mass customization. And I love to show this Netflix illustration. So you might get recommendations. You all know recommendation engines on Netflix, suggest that Rory's going to get different ideas to watch tonight than I will. But what you probably didn't realize, so you already knew Netflix was customizing the messages that they were going to send to each of you. But what you may not know is the way they customize it actually, not only does Rory get a different recommendation than me, but he might get different cover art. So actually, Netflix actually customizes the cover art to make different treatment recommendations to everybody. So that shows the depth of which these algorithms can help us with mass customization for things like movies. Can you imagine how we could do mass customization to help us with things like patient engagement, education, and all the other activities that we have in healthcare? So in a world where there's multiple segments, and again, marketing, we've moved out of the clinical realm now to a marketing realm where if I'm taking care of 100,000 people like in a busy medical practice, I have lots of different population segments that I'm caring for. Up until now, we just treat each patient as a patient or maybe a patient based on their disease and not a needs-based market segmentation. But in fact, I could actually do this market segmentation work the same way you do in every other aspect of your life, the same way you have a different feed on, your Facebook page than I do. So we can segment the market into different ideas about information that people are find interesting, different ways of reaching populations. We have lots of different ways in which we can interface with patients to move this information to them. I'll show an experiment we did with Alexa in terms of audio, but obviously we have video interfaces as well. And then we have the wonderful opportunity of behavioral economics to help influence this. And then finally, we actually uniquely right now have an opportunity to get a feedback loop. And that feedback loop, if I ask you to exercise, I can actually look at your watch and see if you're doing it, which is amazing. That was never available before. No, 1 second. So, I think this is a really exciting proposition of how all of this comes together in digitally enabled care. So all of these messages can be customized to different parts of the population. Hang on a second, my computer stopped. Let me just start sharing again. So this is what it could look like, at least in the video world. And this is work Stacy and I did on caregiver archetypes of thinking about personas as different patients as different personas. And if we could think about them as personas and motivations for why they're coming in to seek care today, the really cool thing is actually we could use different language to talk to different people when they come in. And this is really important in a video world. Does this stuff work? And this was a clinical trial we did a couple of years ago of Amazon Alexa to help patients titrate their insulin dosing. And so when patients are on new prescriptions of insulin, we'll give them this complicated sliding scale of how we want them to titrate their insulin. In one arm, we actually did all that work for them through Alexa. In the other arm, they got the standard of care. And what you could see over 60 days is how much more progress people made in terms of titrating insulin doses when all they had to do was ask Alexa for help. And then finally, how does this come together with payment? And so Josh would shoot me if we didn't talk about payment models somewhere in this paper. And in the original version of our paper, we talked about ways in which we could think about fee-for-service payments and modifying fee-for-service payments to accommodate all of these different digital services that we've outlined in this paper. But one of the reviewers was really astute and came back and said, well, why are you talking about episodic payment models for all these things? Where the Internet of Things is continuous. Why aren't you thinking about more continuous payment models? And the final version of the paper accommodates that with an idea of subscription models. And we really like the concept of subscription models rather than capitation models. So in the old days, we thought about capitation as a way of kind of balancing the service provision to patients, or frankly, restricting access to services for patients. But in this digital world with all these digital services, there is no reason for us to restrict access to all these services. The marginal cost of them is zero. And so I really like the idea of subscription models, much more than capitation models as a way of paying for this. And as a policy level, at a national level, imagine if we took 10% of our health insurance premiums and put that towards primary care and prevention. Not only would we do something really dramatic to improve the health of the population that we serve, but then that would give us an impetus to really build out these digital tools under that new payment model. And so that could be really exciting path forward. So happy to talk about more about this, but I think a couple of things from this work and from all of our work at Biodesign is all this, despite all this excitement about AI, it doesn't change the paradigm. It starts with needs finding, with identifying the problem, not with the solution. And so in our case, our problem was about patient engagement, ways to build improved models of care. It's a really interesting time to think about changing paradigms and how do we bring this forward. Obviously, both on the technology side and on the political side, everything's up for grabs right now. So it's a really interesting time to think about bringing these concepts forward to improve patient care. So let me stop there and say thank you and turn it over to our next discussion, Stacy.
Thanks, Kevin. So while I am sharing my screen here, let's see. There we go. So first, I just want to say that I was so fortunate to have crossed paths with Kevin when I did, and to have gotten to work on this. I am a marketing professor, but my mother was a nurse and wanted me to go into medicine. My father was an engineer and wanted me to go into engineering. And so being able to combine my own career in innovation and innovation adoption with sort of the structural problem solving of engineering and the work of clinical care, this is like a personal sweet spot. But a lot of, obviously in 10 minutes, I'm not going to be able to talk about all the different implementation specifics from our paper. One of the things that Sandy mentioned, and I hope is something you see in the paper, is that we have tried to be as specific as possible with recommendations. That's clearly not an exhaustive list, but we wanted to be just really just concrete in the kinds of ideas that we suggested. And so what I'd really like to kind of think about in terms of implementation is, like, as a design group, as clinicians, as innovators, why do you need a marketing professor in the mix? And basically, maybe this is a bit of a bold statement to say what you think about marketing is wrong, but I have a long life of working in STEM and innovation, and I find that a lot of people think that marketing is something you do after a service has been designed, after a new system has been put in place, and you're convincing people to adopt it. But build it and they will come is an absolutely terrible marketing plan. And when Kevin and I were doing a lot of work on COVID vaccination promotion, this phrase came up all the time. In fact, just in speaking with the panelists before the session started, we were just talking about things, and I said, oh, well, as an innovation researcher, I always get my hackles up when I hear people say should, the word should. Consumers should like that, patients should do that. because of course, should is a word that's closely related to scold. And frankly, lots of us don't do what we should do. Sometimes I think about, my own lack in terms of, you want to think of, preventative medical testing, or even just thinking about my financial retirement plans. We don't always do what we should do. And so I want to show you a couple of examples. And these are just things to take with you as we're trying to understand implementation. So this is something that I do when I'm teaching at the School of Medicine to give people a sense of what we're thinking about when we think about marketing and behavioral economics. So imagine this choice scenario. Imagine that you are going to a friend's house for dinner, and on your way over, they text you and ask you if you can stop at the market and pick up a jar of artichoke hearts because they need it for their recipe. You say, fine, this is a good friend. This is a casual dinner. You stop. You don't know artichoke hearts very well. I don't. And you see 3 brands. The Polar brand for $1.79, the Reese brand for $2.69, and the Delalo brand for $3.49. They're exactly the same type of artichoke and exactly the same amount. Which one do you choose? And so oftentimes with the doctors in my groups, I'll ask them to make this choice. And what we commonly see is something that looks like this. So this was the choice share from the last time I did this little thought experiment. And what we find is that 61% chose the middle brand. Maybe if you were thinking what you would choose, that was the same one you thought. And this doesn't explain everyone's choice, obviously. I mean, there's some people who think that the cheapest brand is like artichoke hearts. That doesn't seem important. And other people are like, oh, I'm going to a friend's house. I need to get the best, the nicest one. But still, that middle choice was the most attractive. And so this is a decision heuristic known as the compromise effect. And I'm sure you've run into it in many aspects of your life, but it's basically our human tendency to favor middle options whenever there's any uncertainty involved. I don't know artichoke hearts. I don't know which are the best brands. Let's just go with the middle one. And the interesting thing about this is that it really suggests that our decisions are a function of the context in which we make them. So let's imagine instead of seeing 3 options, the ones we saw before, there's a 4th option. There's the Matisse brand at $4.99. And so what happens in this case, and again, I do this where then some of my students answer this question. And again, last time I did this thought experiment, I'll show you what the findings were. How do you think this is going to impact Delalo? Delalo is the product that used to be on the edge of the choice set at $3.49, but now is in the middle. And as you might suspect with the name compromise effect, it's suddenly more attractive. And so you can see that without changing anything about Delalo, not anything about the product itself, it's more preferred in the population simply because where it is within the choice context. Now, when I first started teaching in the clinical informatics master's degree, we would talk about this and we talk about compromise effect. And people say, well, is this in healthcare? Like, what does this have to do with digitally enabled care? And I'm like, it's all over healthcare. So one of the things that struck me the most when I first started doing research in healthcare and healthcare innovations, and just honestly, healthcare decision-making, I did some shadowing where I followed doctors in the neuro ICU. And what I found in that situation is that one of the places where people were worried that patients' loved ones were having a really hard time making a decision was when they were asked whether they wanted to withdraw life support or continue life support. So, imagine a patient comes in, they've had a catastrophic stroke. There's, no foreseeable brain activity that would indicate a recovery. And now you're talking to all the family members who are having like a horrible crisis and are all gathering there and grieving and worried. And then you take them aside. And I asked, like, how do you get people to make this decision? And it turns out that a lot of people just are kind of taken aside and given 2 choices. Do you want to withdraw life support or do you want to continue life support? At any time we're in a decision with uncertainty, 2 choices feel horrible because they both feel extreme. And so I talked to one nurse who usually had this task in her particular department. And she said, and I quote, "I feel like I'm offering people a choice between a Pinto and a Porsche." And that's really interesting because so many times we think medically that the best decision is some kind of, option that people don't choose. But, how could that be a middle option? How could there be a middle option here? I've thought about this situation, and could you offer people a chance to say, well, here's the situation, and here are your 3 options. We can withdraw life support today. We can make a plan to withdraw life support in X number of days when where we'll be watching for signs. Or we can simply make a plan to continue life support until some undetermined time. And when you give people that middle option, you're going to find that people feel more comfortable and more confident with it when there's uncertainty. And so that's really a great example of what's at the heart of consumer behavior. So consumer behavior is a marketing field where we look at the logical utility of things, like the actual value someone would get from having discharge papers. Instead of papers, have videos. Instead of having videos just in some generic language, having it in their own language at their own reading level. We look at the logical utility of that. Then around that layer of logical utility, which is kind of, if I must say so, is the level of decision-making oomph that a lot of STEM people, engineers, bench scientists, like logic-driven people think, there's the gist of the decision, the logical utility. Yes, but surrounding that are decision heuristics, the context in which we make the decision, like the compromise effect. And around that still is the influence of culture. And so culture might be something like I also heard in neuro ICU, where I was talking to some people about patients, and I talked to some patients. And what I heard was that some patients, this was in Durham, some patients felt like they wanted their loved one to stay on life support for as long as possible, not because they thought that person was going to recover, but because that person was in a minority racial group that was not appreciated in the town of Durham. And it was their sort of social political statement to say, my grandmother deserves this room, and you're not going to kick her out of it for some other rich, more preferred person. And that's a really interesting thing because it shows how narrative and the meaning behind things then also influences our decisions. And all of those layers combine. And I have a little shout out here to design thinking, because obviously design thinking is a really great way to contextualize the value of consumer behavior, because it's easy to think that we would put this little nugget at the end of design thinking to try and use it to implement things we've designed. But actually, the success of the implementation depends on that little nugget being at the beginning, when we start to empathize with the end user. And that can be a patient, that can be a clinician, that could be a payer. I mean, I really think that when we think about what are the needs, as Kevin was saying, and what are the heuristics and the cultural narrative around these things, there's lots of times when what sounds really logical is actually perceived in a totally different way. And when you see the lens that someone's using, it makes sense. But if you don't have that lens, it really seems like quite wrong. And so that's all that I wanted to say in terms of why marketing. I want to say that when we look at things like, so in that list of suggestions, one that really is close to my heart is it says list other, during the visit, list other clinicians that the patient is seeing, so that the doctor they're talking to can see who else is there, and even maybe have like to-do charts, to-do lists off of that. It comes from a situation where my dad was in an accident not too long ago, and he had this weird hematoma on his elbow, and he had a PT that he saw, he had his neurological person he saw his regular practitioner, and then he had a dermatologist, and they all thought that another person was taking care of that hematoma. And so it just dropped through the cracks, right? Like no one said, hey, go get this taken care of. They also assumed someone else on his care team was doing that. And, you know, it ended up leading to a really bad situation that was just kind of caught in the nick of time before he had real joint damage. And I think to myself, that's the beauty of these AI designs when you think of them in terms of single use cases and then build out, right? Think of a specific segment and then see if you can scale up, rather than coming up with the thing that should work for everybody and then trying to make it specific to a segment, right? Like don't start and then try and design down, but rather start small and then scale up to different segments. It's a lot easier, and it's a lot more likely that you'll hit people's true preference. We have an old chestnut in marketing that says, you know, if you're, you know, the world loves tea. And so if you want to sell tea globally, you might think that you need to sell lukewarm tea, since half of the world loves iced tea and half the world loves hot tea. But that would be exactly wrong. So I think in medicine, we sometimes, you know, all of your research is designed to know what the, you know, kind of the main, you know, best standard should be, rather than the idea that there might be a bunch of very fragmented segments that all have different preference structures.
Thank you so much, Stacy. That's great. I think what we're going to do now, we're going to transition to Rory, who's going to tell us a little bit about his own real world experience, both with some of the needs that underlie the ideas of the digitally enabled care framework, and then also some of his perspectives that he's gained from his work on value-based care models and more recently at ARPA-H. So I'll hand it over to you, Rory.
Thank you so much, Sandy. And I really want to also thank Stacy and Kevin for involving me in this project, because you know, it really does resonate with my personal experience as a doctor. I was a primary care physician practicing before, during, and after the pandemic. And in the paper, we talk about the incomplete transition that's currently undergoing in healthcare between kind of traditional in-person to hybrid virtual care. And I certainly felt that. And one of the things that I think some people may not really understand is the variation in needs from patient to patient. So many of my patients, especially those who are younger and healthier, I would communicate almost entirely through messages, and, you know, maybe have a video visit here and there. And folks that required or valued kind of convenience above all else, and that, you know, contrasted very markedly from perhaps older patients that have multiple chronic conditions and require more of you know, dedicated in-person time, and as well as a continuous relationship, but perhaps don't have facility with using messaging. And so I think trying to respond to both of those needs for large groups of patients is part of what is contributing to many clinicians feeling kind of overextended and underappreciated in today's healthcare system. And what I think is so valuable about the digitally enabled care model is it provides a framework that's flexible and allows us to use some of these new tools to better accommodate these very variable needs from different patients in a way that provides value to patients from the visit as well as clinicians. And then crucially, it reinforces instead of detracting from the physician-patient relationship. I think that's one of the things that's also being balanced, is that with many clinicians feeling very overloaded, there's various different strategies to try to offload some of those messages or some of those strains from the clinician. But if that's not done carefully, that can harm care coordination, as Stacy explained. One hand doesn't know what the other is doing if there's more people involved. And then also, I think, especially for primary care doctors, but many clinicians, like what they really motivates them is that building the relationship with the patient that's therapeutic. And so if it's kind of partially outsourced to a digital tool, that may not be appropriate. And so what I think it all comes down to is that there's kind of warranted and unwarranted variation. So every patient wants to be valued as an individual and have their care kind of customized to them. But we also know that guidelines and having standards for quality of the care that's delivered is also important. And so having a flexible framework that can balance these competing needs is really well needed, and I think is what will help make sure that we get meaningful value out of these new AI tools that actually serve what patients care about, instead of perhaps intermediate measures that in the end don't really matter. So Sandy, I can go ahead and pass it back to you, as I think we may be short on time.
Yeah, no, I think let's open it up to questions here. We have about 10, little bit over 10 minutes left. So if you've got any questions, please put those into the Q&A, and we'll feed those up to our authors here. And in the meantime, I think one of the things, Kevin, I'd love to hear more about from your perspective is what kinds of transitions are necessary from a payment model perspective to implement some of the ideas here. I think particularly these pre and post visit models, they provide a lot of opportunity for value, but I think at least it's my perspective that the impression that they're going to need a significant amount of either reform or innovation from a policy perspective.
Yeah, I mean, I think that's a great question, Sandy. So we're struggling. Like when we don't provide services. So, the next talk will be about inbox messaging crises, right? So we don't provide patients with any post-visit digital services, and yet we wonder why, we've taught them how to engage, and then we're overwhelmed with these tools. So at one level, conceptually, I think we have to understand we're putting out a fire that we're creating. And at the broader level, we're struggling as a country for primary care access, and a lot of that's because we don't have a good payment model for primary care. So we could actually take that, the impetus right now for what do we do about primary care, and roll this into primary care and build a really robust payment model. From the perspective of sitting here in Silicon Valley, if 10% of health insurance premiums were directed towards primary care and prevention in some kind of hybrid model, we'd have all kinds of firms that would love to participate in that ecosystem. That would provide amazing digital tools that would dramatically enhance patient engagement, help them in terms of compliance and education. So I think you could we could do it through a fee-for-service model with some of these codes that are slowly rolling out. But I'm actually a lot more excited about, why don't we start from the beginning, plans are carving out pieces of the benefit package anyway. They carve out oncology sometimes. Let's just carve out primary care and prevention. Health plans are doing a lousy job of funding that. And then really build a powerful set of services for patients.
Yeah, Kevin, I see the question in the Q&A about how far have you come with pitching this idea for 10% for prevention with health plans. Is, how feasible do you think that idea is, and what would it take to actually take it that next step?
Yeah, I brought it here to our university treasurer, and of course he retired the next day. When you look at it, we're struggling with a couple plans that told me they're about 5% primary care and prevention. I will tell you, UCLA this year, the graduating class of the medical school at UCLA, no, not one student went into pediatrics. Okay, so it's a crisis. If we're not going to provide people with a living, they're not going to do these fields. And it's not, when we have 72 million Americans in Medicare, it's not a really good time not to have primary care docs. So primary care is a crisis, and then roll this set of services up, and to me that becomes really attractive. I don't think I've talked to some like MA plans that are thinking about going to like 15% of premium towards primary care, specifically so they can keep people out of the emergency room. I mean, if we're penny wise and pound foolish in terms of how we pay for things right now.
Yeah, great point, Kevin. Great point. Rory, I'll field this next one towards you. That the question here is the digital model and payment model is very nice, but this questioner is afraid that clinicians still lack time to utilize and promote them. What are your own thoughts on how you might integrate some of these tools into a busy practice?
Yeah, that's a great question, and kind of dovetail with what Kevin was saying as well. One of the things that we include in the paper, which I think is a very salient point, is that any kind of future payment model should not add to the administrative burden of clinicians. So one kind of, I think, illustrative argument is that these messages are a real kind of thorn in a lot of clinicians' sides because there's dozens, sometimes 50, 100 messages answered a day. And a lot of times clinicians feel like they're not compensated or thanked for it. And so I know one of the things that has been bandied about is paying for individual messages. And then I know I was in a group and so it was starting to be explained about what you would need to do to make sure that is billed for and all the different things to collect and so the clinicians quickly said, you know what, we'll just respond to the messages. And so I think that in a lot of the different alternative value-based payment methods have required a large burden of reporting and quality metrics, and that has led to a big backlash. And so I think that we just need to keep it simple. And that's one of the great things we talk about in the paper. Instead of having to bill individual services and individual disease management codes, that a patient could simply perhaps get a certain number of touches in a month. And then they could decide whether that would be in person, a video visit, messages, what works best for them. And that might be one way where we can make both the clinicians and the patients happy.
Nice, great. And any kind of payment transition, like let's link this specifically to payment. Like what, if you had to think about like, what's the first step towards this? Do you have any examples where you think you're seeing that happen or what might you want to see?
Well, I think we need more. I would hope for more substantive changes. I mean, I know that there are things like these add-on payments to the E&M codes. But as I mentioned before, that creates almost like a cottage industry of coding and administrative work, which is somewhat counterproductive. So what I would favor is evolving towards more of an outcome-based payment system. The work that the team that I'm on with ARPH and proud to contribute to is we're developing the Heroes program, which is rewarding communities for improving health outcomes for entire, populations of patients that are in the millions. And I think in the end of the day, as a society, that's what we really care about is whether people, receive the health care that is going to lead to longer and happier, healthier lives. And that, the payment reform to get here to there, it would require many different steps and legislation. But I think there's two things. There's the financial incentive to have better outcomes, and then there's the actual practical abilities to improve population health. And I think we've seen, in the aftermath of the Affordable Care Act, that it's actually not so easy to manage population health, especially with limited resources. So I think that's the tricky part is how do we get from our current payment system to something that pays for what we care about, in a practical way in the current political situation.
Great. Thanks, Rory. Stacy, I'd love to send a question back your way. You talked a lot about what I might even characterize as psychographic profiling and market segmentation around different patient factors. Do you want to elaborate on that a little bit? Because I feel like in healthcare, we don't spend a lot of time talking about this kind of specific granular segmentation, and yet it's showing up so much in our consumer products today.
Yeah, it's interesting when I first started working with people in medical situations and medical decision making, how little looked at some of the things that, say Apple or Nike or, basically, these kinds of titans of retail would look at. And some of them are really simple, like, risk aversion. To what extent is someone risk averse versus risk seeking? Some of it is how you process information. Kevin and I published a paper in JAMA that looked at whether people's lack of getting the COVID vaccination was due to the fact of whether they were on a psychological spectrum high involvement, meaning they were very highly involved and negative, which is resistant, versus low involvement and negative, which means apathetic. And like tackling resistance versus apathy are two totally different things. And so knowing a little bit more about the psychology of the segment you're dealing with, I think one of the problems with talking about that now is that it already seems like such a big job just to build these structures out. It seems like, oh, are you asking me to build out 1,000 different structures? And the answer there is no. You build out your one structure, but AI is the tool that allows you to kind of fluidly and seamlessly and not effortlessly, but with ease, look for differences among people and how they value different things. There was an interesting thing that Rory said about younger people liked messaging and televisits because they're convenient. Well, what if televisits weren't just convenient? What if they actually gave you more information because you could look on a screen and read stuff while you were talking to your physician? Right? Like that's the kind of stuff that some people are going to want and some people aren't going to want. And it might be as little as, some people like very formal sorts of approaches and some people like casual. I think there are going to be lots of things that are handled more automatically in the future. It's not a case of, we have to have 100 different ways and clinicians have to measure, have to now, have 100 different ways to talk to people.
Yeah, I think that's absolutely true. Kevin, let's wrap up here with one last question towards you. If you had a wish list, where would you think about implementing this digitally enabled care framework first? What would be first preventative intervention you would go for?
Well, I think we are implementing these pieces of these. So, the Alexa and the voice assistant is now a company called UpDoc that's moving forward in the field. As co-chief of hospital medicine, we're doing discharge planning to give people, I've challenged everyone to make sure we can get the information in video using AI and LLM. So I think that technology use cases that we've outlined are really starting to develop. We still haven't developed a payment model and we haven't put it all together in a way that demonstrates the value. So I think that's all coming. But I think all of these things, it wasn't rocket, it wasn't science fiction. This is all stuff we could do today. But this is healthcare. If there are things that should be there that aren't, there's a reason, and we have to go back and figure that out. And a lot of this is payment models, unfortunately. But if we're really serious about improving population health, which is the message that we're getting, this is the way to do it. I could touch base 365 days a year with every single patient. And, all of us who have digital watches who, my wife now, the walk doesn't count unless the digital watch, tracks it. Well, there's a whole nother set of population that doesn't do that. you know, and we're fooling ourselves if we don't figure out how to build digital tools for them. Like it's more important to get the people, you know, sitting on the couch with diabetes up and moving than to get me another 100 steps.
Yeah, great. All right, well, I'm going to wrap it up there. Thank you so much, everyone, for joining us today. I also want to thank again all of our panelists who were here today. Kevin, Stacy, Rory, thank you so much for doing this. And thank you, everyone, for joining today. You should be able, we will take this webinar and turn it into a recording, and you'll be able to find it on the policy program portion of the Biodesign website here, you know, with a fairly short period of time. So hopefully you'll get a chance to review it later if you missed any of it. All right, thanks everyone. Have
Thank
a
you.
great